دكتور رمزي.
القطان قال ابدو.
بس نشوف السبيكر جاهز عشان بعد تصير.
ابدو يا رجال جاهز معي.
شوف دكتور.
Good morning. Assalamu alaikum. We would like to start our first session for the second day. So it gives me a pleasure to introduce our moderator of the session, Dr. Ahmed Al-Zuani. He's a consultant neonatologist and head of the neonatal section of Maternity Children Hospital in Abha, and he's the director of neonatal perinatal fellowship program there. And the second moderator is Dr. Hatim Al-Umari. Dr. Hatim Al-Umari is a consultant neonatologist and, at Jeddah East Hospital, and he was the previous CEO at King Abdullah Medical Complex. We can start our session for the day.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everybody. We will start the fourth session today. Our session is neonatal respiratory, and our speaker, the first speaker, is Dr. Ramzi Kilani. Dr. Ramzi Kilani, he's a consultant neonatologist. He's a director of Neonatology Unit Point Methodist Hospital, Illinois, USA, assistant professor of medicine, Illinois, Chicago, University of Illinois at Chicago, and head of clinical practice guideline committee on site. And he will talk about the volume target ventilation. Welcome, Dr. Ramzi.
Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. I would like to thank the organizing committee and the scientific committee for inviting me to be presenting to you this morning. We're going to be discussing the volume target ventilation in neonates. And I would like to start with reviewing the mechanism of ventilator-induced lung injury and lung injury sequence, inflammation sequence, and how to prevent the villi and LIS using an open lung and using controlled tidal volume, and then review the volume target ventilation. Why volume target ventilation? Because we intend to minimize volume trauma, but also it's an auto-weaning, auto-PIP adjustment. We know that volume trauma, not barotrauma, is behind the villi. Whenever there is inadvertent hyperventilation, which is common with conventional mechanical ventilation using pressure, that results in hypocarbia, which is bad for the brain and the lungs. And controlling for the volume becomes critical. We know that from this study that hypocarbia in the first 3 days was common using IMV and BTV ventilation, and that results in significant morbidity of cystic, PVL, IVH, grade 3, 4, and cerebral palsy, depending on how low the CO2 can go. But not only hypocarbia, but as well hypercarbia is not uncommon when you don't control the volume, and that can also result in morbidity. The ventilator-induced lung injury, back in 1973, the first recognized form of ventilator-induced lung injury was named barotrauma, which stressed the role of pressure as a causative agent. However, in 1988, after the works of Dreyfus et al., volume trauma was recognized as the primary driver of villi. In his work and his group, they studied rodents, and they used the 3 modes of ventilation. One, they used high pressure and high volume. The yellow, they used low pressure, which was